The committee will come to order, and I cannot tell you how proud I am and Mr. Camp are in terms of being one of the lead committees in tackling a very serious and national problem. It is the hope of our new president that all of the people, not just the patients and potential people in need of health care, could come together, insurance companies, government, local and state people, unions, management, as he brought us together at the White House to see how, at the end of the day, we can make this country more healthy. It involves our workforce, international trade, competition, cost, prevention, reimbursement, universality, and I really believe on the House side that we can do it, notwithstanding the fact that more than one committee has jurisdiction. And so we will be working with the Committee of Energy and Commerce and Education and Labor, not only in formal hearings, but informally, Republicans and Democrats, to see if at the end of the day we can get a bipartisan piece of legislation. This gives us an opportunity to reform the system, to deal with reimbursements, to deal with a variety of things, because there's no question that the health care system in our country has broken down. So it's not just a question of the 46 million people that are not covered, it's also the cost to other people who have coverage, because these people are getting health care and the government and private companies are paying for it. Most all of the work on this has been done by Mr. Stark, Chairman Stark, and his subcommittee, and I would like now to yield to him to get his views for the direction which the full committee will be taking. Mr. Chairman Stark.
Well, thank you, Mr. Chairman, and thank all of you and our witnesses. We made some moves toward what President Obama has talked about as a moral and economic imperative for our economy. And as we'll hear today, the quality of our health care is based on geography, health insurance status, the number of uninsured in our community, a whole lot of things that aren't really relevant. We did deal with health IT and made a step toward comparative effectiveness research, but with those advancements, our healthcare system will still be inefficient and unfair unless we do what virtually every other nation in the world has done, and that is extend coverage to everyone. You've got cost shifting and a fractured system, and unless we have a system where everybody is part of it, a part of the program, we won't have achieved our goals. We can improve a lot of things in Medicare and Medicaid and SCHIP, but when we talk about reform, I guess I think of coverage for everyone. And it's interesting that more than 2/3 of the public, in the polls at least that we've seen, believe that they want an option to choose between a public plan or a private plan. And that seems to be at least the direction in which the committees are going and following the President's request. We're going to hear from 3 witnesses this morning. We're going to hear from the Institute of Medicine, who's going to tell us about the cost of being uninsured, and it has a lot of ramifications other than bankruptcy. We'll hear from the Commonwealth Fund, And they've spent a lot of time designing an outline, I guess they call it a framework. They've reviewed, my only disappointment was once they reviewed all the health plans that were available, and mine came in first. So I think they didn't like that, so they wrote their own. So that's okay with me. Then we will hear an actuary, Millman Incorporated, and I do want to note that their analysis was conducted on behalf of the health insurance plans and the Hospital Association, and MedPAC takes exception to the analysis, and I would ask that MedPAC's statement prepared for the record for today be made part of the record. And we'll proceed, if the chair is with Dr.
No.
Oh, I'm sorry. With
I
Mr.
want to
Camp or
say,
Mr. Herger or whomever.
with Mr. Kemp, that it appears as though the other body is attempting to proceed in a bipartisan way. I don't know whether we will have that flexibility, but I hope after we listen to the witnesses, we can determine whether there are serious differences in the approaches that we are going to take. But if indeed they're not serious, then whatever can be worked out, I would hope we would at least try to work it out. So I yield to you whatever time that you like.
Well, thank you, Mr. Chairman. As you've said, this is an important hearing following a historic meeting at the White House last week, and I first want to thank the chairman for so readily turning over the microphone this time. I know with, if we cooperate with this, I think there's really no limit on what we can accomplish together. But too many families are struggling to pay for their health care. Too many employers are being forced to reduce or eliminate coverage. And yes, too many Americans are uninsured. These are facts that we all agree on. And as I told the President last week, I think there is broad agreement on the principles of any successful health care reform: lowering costs, increasing access, ensuring portability, having a strong prevention and wellness component, among others. The difficulty is, how do we get there? And that's why I want to begin my remarks by highlighting one fact, that 61% of Americans have their health insurance through their employer, those of 65 years and under. And let me also say that 65% of Americans less than 65 are covered with some form of private insurance. And the reason I wanted to highlight those numbers is just for one specific reason. It's clear a majority of Americans receive their health care through their employer or other private means, and I think the first principle we must follow in health care reform is protecting the coverage Americans already have, and that's the coverage they receive through their workplace. Increasing the government's role in health care has a cost for taxpayers, and as Mr. Pickering will testify, for employers providing coverage and the workers they cover. This government to employer and employee cost shift will eliminate the manner in which about 120 million Americans receive their health care, and that runs the risk of violating the Hippocratic Oath, which is first, do no harm. Sometimes on television you see an ad for new medicine and the latest cure-all, and as usual at the very end of the commercial you hear what the side effects are. You might hear mild nausea and you think, well, okay, an occasional headache, that might be worth it, but a fatal stroke, that's obviously not a chance. That, I fear, is exactly what some witnesses today are asking us to risk, a fatal stroke that will eliminate the ability of employers to offer affordable health care to their workers and their families. Mr. Chairman, you well know that employers are already having enough difficulty maintaining coverage for their employees, and I think you would agree with me that they deserve to be commended for giving millions of Americans access to critical care. Let's obviously make sure that we continue to support them and their employees. I look forward to working together to make sure health care remains a benefit provided by employers while driving down high costs of care that every single American faces, and I look forward to working with you on trying to see if there is a path forward to ensure that more Americans have access to health care, more Americans have insurance, and the reforms of wellness and prevention are incorporated into any plan that might move forward. So with that, I yield back the balance of my time. Thank you.
Thank you. We have three witnesses today, John Arian, Karen Davis, and John Pickering. And the chair would ask John Arian, who is a doctor from the Institute of Medicine, Committee on Health Insurance Status and its Consequences, and a professor of medicine and healthcare policy at Harvard Medical School. He will be testifying on behalf of the Institute of Medicine Committee and about their recently commissioned report summarizing the research on the effects of uninsurance. And we look forward to your testimony. The procedure is that you'd have 5 minutes, but you will be allowed to finish your thought on that. So welcome, and we welcome your testimony this morning.
Thank you, Chairman Rangel, Representative Camp, and members of the Committee on Ways and Means. My name is Dr. John Ianian. I am Professor of Medicine and Healthcare Policy at Harvard, a practicing physician at Brigham and Women's Hospital in Boston, and a member of the Institute of Medicine Committee on Health Insurance Status and its Consequences. I'm honored to present to you today the Institute of Medicine's most recent report, America's Uninsured Crisis, Consequences for Health and Health Care. Our report addressed 3 key questions. First, what are the dynamics driving downward trends in health insurance coverage? Second, is being uninsured harmful to the health of children and adults? And third, are insured people affected by high rates of uninsurance in their community? The first topic of our report assessed the continuing decline in health insurance coverage. With eroding private coverage and expanded public programs from 2000 to 2007, the proportion of uninsured children remained steady at about 11%, while the proportion of uninsured adults increased from 17 to 20%. The principal cause of declining private insurance coverage has been the rising cost of health care. Between 1999 and 2008, family health insurance premiums rose nearly 120%, more than triple the increase in workers' earnings. Employers are less able to sponsor coverage, and employees are less able to afford the premiums if coverage is offered. Our committee concluded that these trends will not reverse without concerted action. Current economic conditions and rising unemployment will only exacerbate the problem as more individuals and families lose employment-based coverage. The second major topic of our report focused on the health consequences of being uninsured for children and adults. Based on nearly 100 new and generally stronger studies that we reviewed, we found that uninsured Americans frequently delay or forego doctor's visits, medications, and other effective treatments, even when they have serious or life-threatening conditions. Uninsured children receive fewer immunizations and basic dental services. With serious conditions such as asthma or diabetes, they have more unmet health care needs. Uninsured children are also more likely than insured children to miss school due to health problems. Among uninsured adults, 40% have one or more chronic conditions such as high blood pressure, diabetes, or depression. Many of them receive little or no medical care, and their health declines more rapidly than for insured adults with these conditions. Uninsured adults are also more often diagnosed with later stage cancers. As a result, they are more likely to die prematurely than insured adults, and with serious conditions such as heart disease, cancer, or trauma, their risk of death can be 40 to 50% higher. Fortunately, our committee also found good news to report about the benefits of gaining coverage. When uninsured children gain coverage, they have serious health problems identified sooner, better preventive services, fewer hospital stays, improved asthma outcomes, and fewer missed days of school. When uninsured adults enroll in Medicare, they receive more appropriate tests and treatments that improve their health and prevent costly complications. Their risk of death is also reduced when they are hospitalized for heart disease and other serious conditions such as strokes or hip fractures. Therefore, our committee concluded that lacking health insurance is hazardous to the health of children and adults. More importantly, gaining health insurance provides substantial health benefits to uninsured Americans. The third and final topic of our report focused on the effects of high rates of uninsurance for Americans who have health insurance. When rates of uninsurance in communities are relatively high, insured adults report more difficulty obtaining needed health care and less satisfaction with the care they receive. Furthermore, weaknesses in local health care systems are intensified by high rates of uninsurance, and these problems have potentially grave consequences for the quality and timeliness of emergency services and trauma care for everyone in the community, both insured and uninsured. In conclusion, we determined that the evidence on the adverse health consequences of being uninsured is stronger than ever before. This evidence makes a compelling case for urgent action because insurance coverage matters for the health of children, adults, and communities. Given the harms of lacking health insurance and the benefits of gaining coverage, the Institute of Medicine recommends that the Congress and President work with other public and private sector leaders on an urgent basis to achieve health insurance coverage for everyone, and to reduce the escalating costs of health care to make coverage for all sustainable for the nation. Thank you.
I'd like to introduce our next witness, who's a friend of the Congress and has been so helpful to us even when she's thought we were wrong. Mr. Stark.
Well, I'm pleased to introduce the person for this committee who needs no introduction. Karen Davis, who is president of the Commonwealth Fund in New York, has spent much of her career and directed untold resources from the Commonwealth Fund towards studying the ways we can improve the delivery of health care in this country. And they have come up with, as you suggested in the 11th hour, and I think we all have a copy of it with us, a plan, a scheme that would accomplish a good I'm sorry. She too has hired an actuary. But I think it's important to note that whatever the exact numbers in your report are less important than the direction that the curve moves. I don't think at this point it's worth arguing about the exact dollars. It's the fact that we'll have trends which will get us over a period of years to savings, and those savings will allow us to provide quality care to more people. So, Karen, I look forward to your enlightening us this morning. Thank you.
Thank you, Representative Stark, for that gracious introduction. Mr. Chairman, Mr. Camp, members of the committee. Really, it's a great opportunity to be here on this very important hearing on health reform in the 21st century. With the economy in crisis, healthcare costs rising, as Representative Camp said, too many families are struggling with the cost of health care and the cost of health insurance premiums, and too many employers are cutting back on coverage. We can certainly do much better than we're currently doing, and we can't afford to continue on our current course. It's urgent to start now. In fact, the longer we wait, the worse these problems will get, and the more difficult they are to confront. As Representative Stark said, the Commonwealth Fund Board of Directors established a commission on a high-performance health system in 2005. They have recently released the report that we're pleased to share with you on the path to a high-performance U.S. health system, a 2020 vision, and the policies to pave the way. There are 5 key strategies in the Commission's report. Affordable coverage for all, including an insurance exchange that gives employers and individuals choices of private plans, and a new public health insurance plan that would change the way the insurance markets work, fostering competition, enhanced choice, while preserving, as Representative Camp stressed, employment-sponsored insurance. The second strategy is aligning incentives to reward physicians, hospitals, and other providers for the results we would like to achieve and enhance value, moving away from fee-for-service payment. The third strategy is changing the healthcare delivery system to reward accountable, patient-centered, coordinated care. The fourth strategy, which the Congress has already moved forward with the American Recovery and Reinvestment Act, is to provide the support to hospitals and physicians that they need to provide benchmark levels of high-quality care by investing in infrastructure and information, promoting health and disease prevention. And the fifth strategy is leadership and collaboration among private and public stakeholders to achieve these goals. As Representative Stark stressed, the exact numbers can differ depending upon models are being used, but the Lewin Group estimated for the Commission the following effects of this set of strategies. It would lower the annual rate of increase from 6.7% a year to 5.5% a year. The effect of slowing the growth in health spending would be a cumulative $3 trillion in savings to the health system from 2010 to 2020. Employers would share in this savings. Employers would save $231 billion over that period, which would provide needed relief to struggling businesses. State and local governments that are hard hit by the economic crisis would save $1 trillion over that period of time. And families would save $2.3 trillion, or $2,300 per family in 2020 alone. So as the central source of financing for coverage, the federal government's costs would increase during early years. The net cumulative cost to the federal government of the PATH framework over the 2010 to 2020 period would be $593 billion. Most of the federal expenses occur in the early years as a result of initial investments. These upfront investments yield a substantial return for the nation, resulting in nearly offsetting all of the increased annual federal spending compared to baseline projections by 2020. Most importantly, the PATH framework would benefit patients, achieving near universal coverage, improving choices. It would increase those covered by employer coverage from 164 million to 196 million. It would improve coverage for, or make more affordable coverage for over 130 million individuals. The U.S. needs to find its own unique path forward, building on the strengths of our public and private health insurance system, fostering a competitive market forces in the public interest, aligning incentives to reward value. The result of this would be bold change on behalf of the entire population. The President has called for such bold change, has advocated the creation of a health reform reserve fund, which, if included in budget reconciliation, would provide the essential start for reform. Medicare can innovate, but it can't go it alone. Reforms to bend the cost curve, improve coverage for those under 65 must be part of an overall system approach to change. The cost of inaction is high. We really have a historic opportunity and a clear path forward to a high-performance health system. Thank you very much.
We have with us an expert in health care. I'll ask Congressman Reichart to tell us more about him.
Thank you, Mr. Chairman. I am very pleased to be able to introduce a constituent of mine today, John Pickering. Mr. Pickering is a principal and consulting actuary with the Seattle office of Milliman. He has a Bachelor of Science degree in mathematics from Central Washington University, which is, take a moment to boast a little bit, the same university my son received his mathematics degree from. He also has a BA in communications from the University of Washington, more than 10 years of health actuarial experience, and he currently resides in Sammamish, Washington, grew up in North Bend, Washington, all within the 8th District of Washington State, and I'm very much looking forward to hearing his ideas on how we can improve and reform our current health care system. Welcome, Mr. Pickering.
Thank you, Representative Reichert, for the introduction, and thank you, Chairman Rangel, Ranking Member Camp, for the invitation to testify this morning. I'm John Pickering, a principal and consulting actuary with Milliman in Seattle, and I appreciate the opportunity to contribute to the healthcare reform dialogue. Milliman is the largest actuarial employer in the country, with offices in approximately 30 U.S. cities. In healthcare, we work with health plans, providers, employer groups, and government entities nationwide. We recently conducted a study of hospital and physician payment rates among Medicare, Medicaid, and commercial payers at the request of AHIP, the American Hospital Association, the Blue Cross Blue Shield Association, and Premera Blue Cross. I will summarize the findings of our study in my testimony today. My goal is not to advocate for or against any specific reform proposal, but rather to help inform the debate. We measure the cost shift as the change in provider payment that would be required by Medicare, Medicaid, and commercial payers, such that all three would pay equivalent rates. Together, these three main payer types must also cover the unpaid costs for services for the uninsured. Chart 1 presents our findings for hospitals. This is based on 2006 data. We estimate that on average, hospitals had a negative 9.4% margin on Medicare patients, a negative 14.7% margin on Medicaid patients, a 23.1% margin on commercial patients, and a negative 25.1% margin on uninsured and other government patients. These combined for an overall operating margin of 3.8, with the Medicare, Medicaid, commercial subtotal operating margin of 6.4. In order for each hospital to achieve consistent margins on Medicare, Medicaid, and commercial business, we estimate Medicare and Medicaid combined would have needed to pay an additional $51 billion, and commercial payers would have paid $51 billion less. This would amount to an 18% reduction in commercial payment rates. Table 2 presents our findings for physicians. This is based on 2007 data. The values in Chart 2 represent relative payment levels. 1.0 represents the weighted average of all three payers. We estimate that Medicare paid 11% less than the average, Medicaid paid 40% less than the average, and commercial payers paid 14% more than the average. In order for each to pay the average rate, Medicare and Medicaid would have needed to pay an additional $38 billion, and commercial payers would have paid $38 billion less. This would represent a 12% reduction in commercial payment rates. Chart 3 summarizes our cost shift estimates. In total, we estimate the cost shift burden on commercial payers is approximately $89 billion. This calculation of the cost shift is revenue neutral to hospitals and physicians. We have held the total payment to providers constant, but reallocated the source. These cost shift estimates are not based on our opinions of an appropriate payment level, but rather are a measurement of the magnitude of the current differences in the rates. The impact of the cost shift varies geographically and by provider. Hospitals vary in their patient mix. Those with higher percentages of Medicare, Medicaid, and uninsured patients face a bigger burden. Hospitals also vary in their cost efficiency. Some hospitals are able to make a positive margin on Medicare. The payment rate differential puts pressure on commercial premiums. Chart 4 presents our estimates of the cost shift impact on a typical family of 4 in an employer-sponsored PPO plan. The left side of the chart presents the total annual healthcare cost for this family, including premium and cost sharing such as deductibles, copays, and coinsurance, and split between amounts paid by the employer and the family. The right side of the chart represents the amount that is due to the cost shift. In total, we estimate that if the cost shift were eliminated, healthcare spending for this family of 4 would be reduced by almost $1,800 per year, or 10.7%. We were able to evaluate hospital margins going back to 1995. Chart 5 presents the results. Commercial margins bottomed in 1999 and have increased since. Medicare margins peaked in 1997 and have since declined. Medicaid margins began declining in 2003. The rising commercial margin indicates that the trend in payment from commercial payers has exceeded the trend in hospital operating cost. This excess trend has been one component in commercial premium trend in recent years. While my comments today are focused on the financing of healthcare, I also want to acknowledge the importance of improving the efficiency in the delivery system. To be successful in the long term, reform must address both the financing of care and the cost efficiency and quality of care delivered. Thank you.
Mr. Pickering, you've heard the testimony of Karen Davis, and most everybody that I have talked with believe that there should be an option for the potential patient for a public plan. I think your position is that a public plan would increase the premiums and the cost of the private plans. Is that your position?
It could. I believe it could.
You don't believe there's any room for compatibility and competition and wider choice for the potential enrollee in healthcare? Because Shelley Berkeley said at a meeting we had today, our people out there, they don't care whether it's Medicaid, Medicare, private, public. All they want is the assurances that if something happens to them or their loved ones, that they can get affordable health care, quality health care. That's what not Republicans, not Democrats, not people from rural areas or innocent. That is what the average human being wants. Do you believe that you could draft, if commissioned, a plan that would include the public option?
That would be a challenge.
Well, you're a professional, and if
Indeed.
that was the mandate, and if you knew that it was going to happen, and you could say, I don't think it's a good idea, we say, that's nice, but it's going to happen. Do you believe that you could have one that would be fair and equitable to the private providers?
Let me outline what I think the one main concern would be. If the public plan paid at Medicare payment rates, which are significantly below, in most geographic areas, what commercial payers pay, it varies geographically across our country. But in areas where commercial payers currently pay much higher rates, and if Medicare or a public plan came in at Medicare rates, I think it would be very difficult for the commercial plans to compete. Now, could we devise a way around that?
Yes. No, I mean, that's the question, yes.
I hope so.
No, I didn't mean that, I was telling you we could.
I hope so. I do not have the
Because-
answer to that, but I hope
But I don't understand why you would assume that the private companies would be asking for more, or that a public company would be asking for less. I mean, one, the public plan would be underserving the government taxpayer if they were asking for less than what they should. And two, it's possible that the private plan would be overcharging. And if we had this type of thing, you and I would want the providers to know that they're getting an equitable reimbursement where they monitor each other, public and private.
I think one issue is we don't have price competition at the provider level. We only have price competition at the plan level. So, for example, consumers are shielded from making choices of providers on price, such that if or the public plan paid a lower rate to providers than the commercial plans could, it would be very difficult for the commercial plans to compete on premium with the public plan.
If the insurance markets were reformed such as that plans could no longer underwrite, would that help plans lower their administrative costs?
It potentially could. Any insurance reform we would hope would be based on sound insurance and actuarial principles. So, right now in the market, plans need, if we look at the individual market, plans need to medically underwrite so that they don't get selected against. If a plan gets too much adverse selection, its claims cost will grow, and it could face what we call a death spiral, where they retain only their sickest members, and their premium becomes unaffordable. So it's the challenge to pair availability with affordability.
It seems that with your reputation and that of your firm, as you introduced, that you welcome challenges.
Certainly.
But you believe it could be handled if it had to be.
Yes.
Okay. I yield to Mr. Camp.
Well, thank you, Mr. Chairman. Your report really talks about the fact or explains that every American with private insurance is really paying a hidden cost or hidden tax on their health insurance because healthcare providers shift some of their financial losses onto them. And the Lewin Group did a study and said that as a percentage of private payments for services, Medicare, Medicaid, underpaid hospitals, 71 to 67%, and underpaid physicians, 81 to 56%. Can you explain why this cost shift occurs?
Yes, and let me very briefly outline by cost shift what I'm talking about, because it's not just losses on the public programs. In our report, when we're talking about cost shift, we're looking at the difference in payment rates from the overall combined average of commercial, Medicare, and Medicaid. And in those terms, when you think of why the cost shift exists, you need to think of why are payment rates different for Medicare, Medicaid, and commercial plans. There are several reasons. First off, commercial plans are the only entities that need to negotiate rates with providers. The Medicaid fee schedule is administratively set, as is the Medicare fee schedule. For the most part, the managed Medicare and Medicaid will negotiate. Medicare and Medicaid are obviously very large programs. Negotiating power between hospitals and physicians and health plans will come into play in terms of raising commercial payment rates. Also, providers' attitudes towards participating in Medicare and Medicaid. Many providers have it as part of their mission to serve the whole community. So regardless of low payments, they do want to serve these individuals. For Medicaid and S-CHIP, many providers could review or consider that as a replacement for uninsured, such that if they'll accept low rates on Medicaid, because if Medicaid weren't there, there would be the uninsured. So there are legitimate reasons for price differences between Medicare, Medicaid, and commercial plans. What employer groups have been concerned about in recent years is those rates have been widening, putting more pressure on employer premiums.
All right. Assuming we all want to have people keep their coverage if they like it, I don't see how the introduction of a government-run health plan actually lends itself to that assumption. You point out that government-run health programs like Medicare and Medicaid underpay providers, and then providers charge more for their services to those with private insurance to make up for the lost revenue. So won't the introduction of a government-run plan using similar payment policies make it more difficult for employers to continue to offer health insurance, and won't employees find it more difficult to pay for or afford their current coverage if we expand government-run care?
I believe that could be the case. I think there's a few dynamics that could happen. If we consider a public plan in direct competition with a commercial plan, again in an area where right now commercial payers pay higher rates to providers than the public plan would, when the public plan comes in, it will have a large advantage because its premiums, all else equal, would be lower. So people shift from the commercial plan to the public plan. The providers are now paid the lower public plan rates, and there are a few options that could happen. One is those providers could then shift the costs to the remaining commercial population. They could try to. Those providers could become more cost efficient to make a margin under the lower rates, or those providers could simply make less money than they had been making, potentially a loss. In the market today, we do believe that many providers and many health plans do shift those costs onto the commercial market. The dynamic may be different if the commercial market were competing directly with the public plan. The commercial payers then may be less willing to pick up that excess cost, because the dynamic then would be they would be raising their premiums, their costs, and therefore their premiums even higher above the public plan, making them even less competitive. So, it may raise premiums, it may squeeze providers.
All right, thank you. Thank you, Mr. Chair.
The chair would like to recognize the chairman of the subcommittee on health for the remainder of the hearing. Chairman Stark.
Thank you, Mr. Chairman. Well, two things. Karen, first, I wanted to hark back to Mr. Camp's concern earlier on in his opening remarks about the 160 million or however many people get their insurance currently through their place of employment. You have an illustrative list of financing mechanisms, and one of them is capping the employer tax exclusion. And I'd caution, and I think join with Mr. Camp, in doing anything that would undermine the existing coverage for the individuals who receive their health coverage through their employer. And I would hope that as we work on reform and finance it, we can build on what works. And should we be concerned about the effects of capping the employer exclusion on existing coverage, and then what happens to employer-sponsored insurance under the plan you've suggested?
The commission did not endorse specific revenue measures, so it provided for the Congress's and the public's information estimates of what revenues would be generated. But I think your concern that any cap on employer benefits might well lead employers to drop coverage and to erode, in fact, the employment-based coverage that we would like to preserve as one of the essential strengths in our system. By offering competition and choices, by letting employers either directly purchase coverage or bring their employees into a national health insurance exchange with many more private plans and a public health insurance alternative, employers could in fact find more affordable choices. Employees could find more affordable choices. Our estimates are that the number with employer-sponsored coverage would increase from 164 million to 196 million. On the other hand, private plans could compete with that and hold on to much of that business. The first point that I think it's really important that the committee understand is this is in the context of health insurance for everyone. So the Urban Institute estimates that there's $122 billion more revenue that would flow to providers as a result of covering the uninsured. In addition, the Commission's PATH framework recommends bringing Medicaid rates up to Medicare levels. That's another 20 or 30 billion. If one really believes in the cost shift argument that we've heard from Mr. Pickering, then providers should be reducing their prices to commercial insurers. And that will bring commercial insurers down because they don't have to cross-subsidize the care of the uninsured. They don't have to cross-subsidize lower payment rates from Medicaid. The second point, private insurance administrative costs go down when they offer plans through the National Health Insurance Exchange. They don't have the high administrative costs that they have when they have to market individually to small businesses and individuals. So private insurers can compete more effectively by eliminating the cost shift of the uninsured, if it exists, the cost shift from lower Medicaid payments and the lower administrative costs. But private insurers bring to the table many inherent strengths, and we need to tap into those. Yes, a public health insurance plan has the advantages of being a single set of benefits available nationwide, will never go away, and having leverage over provider payments. But private insurers can innovate. They can use utilization management. They can have variable benefit designs. They can select certain groups of hospitals or doctors that have higher quality or more efficient.
Thank you. I appreciate that, and we'll move on. With Mr. Camp, we have about 2 to 1 here, and so we'll do 2 on our side and 1 on your side, if that's okay. And I recognize Mr. McDermott to inquire.
Thank you, Mr. Chairman. Dr. Shaw from Harvard described a single-payer plan as a single set of benefits with a single source of funding. And I understand that that's been sort of discarded in many minds in this Congress. What's hard to understand is the French, for 8% of GDP, provide the best health care in the world when we spend 16% of GDP and have worse results than they have in France. That's according to the World Health Organization. So it's hard to see why we step away from that. But let's talk about the plan that the Commonwealth Fund has put on the table. Is it possible to control costs without a robust public program to compete with the private sector that has been unable to control costs over the last 50 years?
Mr. McDermott asks a very important point. We are at 16% of GDP. Well, actually, almost 17% now,
Yes.
and headed to 21%. Other countries cover everyone at about half the per capita cost of the U.S. But we need a uniquely American solution, and this building on the best of public health insurance and private insurance, giving employers and individuals that choice can tap into it. What our estimates show that if you do not have a public health insurance plan offered to really create this competitive dynamic, instead of saving $3 trillion over this period, one would save $750 billion. That's real money, but it's markedly less. Employers would pay much more without the option of this dynamic change in the insurance market. So instead of saving $231 billion, they would spend $900 billion. It's in an employer's advantage to have access to premiums that take advantage of innovative payment methods, that take advantage of lower administrative costs.
Can I then explore the public option? My biggest fear is that the public option will become the dumping ground for the expensive patients, while the insurance industry continues to siphon off those who are not sick or ill or in certain categories that will make it possible for them to be profitable, leaving the government with all the sick patients, the chronic patients in diabetes, the chronic patients with asthma, all those cases, all the deliveries. Let's get those out so we don't have to worry about any high-cost deliveries. How do we prevent that from happening in the exchange that you're creating here? Because I think that's the real crux of what's going to happen. Industry wants to offload their costs. They don't care where they offload it. And if they can offload it to a private company, that's fine. Or if they offload to the public, that's fine. But we're going to get stuck, I think, with the high-cost patients. It's part of the reason why we have the cost shift in Medicare. The private sector didn't want old people, so the government took them. The private sector didn't want poor people, so the government took them. So we've had all the high-cost patients, and we're headed for another tranche of them, it seems to me, unless we design this very carefully.
That's a very important point. There are two things that it's essential to do. The first is to set rules on the sale of private insurance inside the exchange and outside the exchange.
Nationwide insurance
Nationwide,
rules?
they must take everyone, and they must charge the same premium regardless of the health status, so not charge the sick more. So it's called community rating, guaranteed issue in the insurance industry. Those rules are absolutely important to prevent the kind of risk selection dumping that you're talking about. The second thing it's important to do is what's called risk adjustment. So if chronically ill people prefer a public health insurance plan because it's more innovative about rewarding medical homes, rewarding hospitals for controlling chronic conditions, then we want to make sure premiums aren't higher as a result and that they are risk adjusted. So those two protections are very important.
Does this imply that we're going to take insurance, health insurance regulation away from the states and we'll do it at the federal level?
In this framework, there needs to be national rules that set a minimum standard on the conduct and sale of insurance, and particularly the key ones are exactly what you've appointed to. Same premium for everyone, regardless of health status. It can vary by age if you want to have age bands, and that you have to cover take all comers. Has to be open enrollment, guaranteed renewal. You can't get rid of people because they got cancer. Those protections are very important.
So the patient bill of rights is basically what you're saying has to be built into this.
We will never have security and affordability for American families if we let discrimination against the sick continue in insurance markets.
Thank you.
Mr. Herger?
Thank you, Mr. Chairman. One principle the President has repeatedly stated and that I fully agree with is that people who like the coverage they have should be able to keep it. Mr. Pickering, I think it's very important that we are hearing your testimony on the cost shifting that occurs as a result of inaccurate payments by government-run plans. And the 22.7 million Californians who have employment-based or individual coverage are paying a hidden tax, probably even higher than the 1,788 average you cited, since California has the lowest Medicaid payment rates in the country. I'm afraid there is a real danger of making this hidden tax higher when we talk about placing more people in government-run programs. Mr. Pickering, the Lewin Group has estimated that if a government-run health plan which reimbursed providers at Medicare rates were created, nearly 120 million individuals would be forced out of their current health insurance and into the government plan. If this new government-run health plan was created, wouldn't the current cost shift be made worse, leading to even higher costs for those who wanted to remain in their current private health plan? And what effect would this have on employers who want to continue offering health insurance?
They're charging, oh, is right.
The one thing we know for sure from our study is that right now the commercial plans are paying high provider payment rates. If we assume 120 million people shift from those higher commercial rates to lower Medicare rates, we're putting tremendous pressure on the providers who accept those new patients at Medicare rates. Obviously, their revenue is way down. What options do they have? Try to raise more revenue from the one source where they can negotiate more revenue, which is the remaining commercial population. Become more efficient if they can, or lose money. A change of this magnitude, 120 million people, I would worry that shifting the cost onto the remaining commercial population may not be tenable, just because it would be too large of an amount. I think that in this scenario, it's difficult to know what the outcome would be, but I think there would be tremendous pressure on these providers.
Well, aren't your last two options that they're going to lose money or skimp, isn't that really unrealistic that they would do this? I mean, you can't lose money if you're, now the government we know can continue losing money, that's why they can, we deficit spend, but a private company cannot continue doing that very long, or if you skimp, people are going to move away from your plan. Isn't that in reality correct?
I agree. The hope is that they could improve their efficiency of delivery of care. Is that feasible? Maybe, maybe not. Right now, a lot of physicians balance their caseloads with Medicare, Medicaid, and commercial, with the commercial to offset the low payments. Hospitals will try to attract higher-paying commercial patients for the same reason. If that higher-paying segment goes away, those providers need a new strategy, or they need to readjust to lower revenue expectations, which may mean losses. I agree you can't have losses forever, but
And with that in mind, it seems to me, doesn't it seem just totally unrealistic that somehow the government, that these independent companies and health plans, private, can compete with the government who do not have to, who can go indefinitely losing money as we've been doing in the past? I mean, just on the surface, isn't this just completely out of the realm of reality?
well, in this case, I don't think it would be the government that would be losing money. It would be the providers who are accepting that government payment rate.
I guess I'm switching the question a little bit here. I mean, the whole idea is that we're going to have competition from the government. In reality, it's impossible for the private sector to ever compete with the government because the government does not have to show a profit. They can indefinitely, as we've shown we're doing, run a deficit where a company cannot.
I agree. Even if the government, though, does run at break even on the plan, I think it would be very difficult in many geographic areas for commercial plans to compete, just because in many geographic areas it's not feasible for a commercial plan to try to negotiate rates at 100% of Medicare. They just can't do it.
Difficult, and I'd even say impossible. But thank you very much. Thank you, Mr.
Thank you. Mr. Lewis, would you like to inquire?
Well, thank you very much, Mr. Chairman. Let me thank each of you for being here this morning. It is no secret, and I said it last week and I said again today, that I believe that health care is a right, and it's not a privilege. And as a nation, we have a moral obligation to provide health care for all of our citizens. Today, many of our citizens are one illness away from losing everything. Every day, people put off going to a doctor, even when they know they are in pain. They know they can't afford to see the doctor, and they can't afford the treatment for whatever is wrong. This should never happen in our country, never. This hearing is an important first step as we start the process of making health care available to all Americans. I want to thank you for your studies, your report. I think historians pick up their pens and write about this period. They will have to say that the studies and the reports made a lasting contribution to moving us down the road toward comprehensive health care for all of our citizens. Dr. Davis, why is having a public plan so important? Can we actually change the way health care is delivered and save money, save dollars without a public plan?
It absolutely is essential to getting the kind of performance we want. If we don't, we're going to continue the way we are. I think what we've heard from Mr. Pickering is the insurance companies don't think they can change the way they pay providers, don't think they can achieve efficiencies. We've got to have a different kind of system. We're talking about slowing the increase from 6.7% to 5.5%. Providers have more revenue. Every year they have more revenue. They get paid for the uninsured. They don't get paid now. They get paid at decent rates for Medicaid. But most importantly, they get rewarded for providing better care. They get medical home fees under Medicare, Medicaid, the public health insurance plan. For all the patients that sign up with their practice, they get rewarded. They get additional payments if those patients are up to date with preventive care, if they have their chronic conditions controlled. Hospitals get rewarded if they have fewer readmissions, fewer complications, patients going back into the emergency room or back into the hospital after they've been discharged because they didn't know what to expect and how to take care of themselves. So unless we change fundamentally the way we pay providers, as would happen under Medicare, Medicaid, the public health insurance plan, private insurers are going to continue the way they are now. If they see the light, as they did sometimes with Medicare's physician payment methods in the past, adopt those methods, then we can have even bigger change. But otherwise, we're just going to continue. And who's going to pay? Families are going to continue to pay. Businesses are going to continue to pay, and we're going to have higher federal budget costs. The federal budget cost of covering the uninsured would double without a public insurance plan. You do not want to bring the uninsured in at high commercial premiums, at high provider payment rates. It's a very important option, a plan, a choice to have available in the insurance exchange to make sure that scarce federal dollars are used efficiently to cover the uninsured and improve coverage for the underinsured.
Dr. Davis, in Mr. Pickering's testimony, he talked about a cost shift from public payers to private plan. Now, I noticed, and maybe Mr. Pickering, you can correct me, but I believe your report was financed and commissioned by the insurance company. Do you have any reaction to that? Maybe the insurance companies and the hospital? Seem like there may be a little vested interest there. All right.
There are, I think, three concerns I have about Mr. Pickering's report. The first is it doesn't assume we cover the uninsured or improve Medicaid rates. If we did that, most of this cost shift goes away. If providers get $122 billion for the uninsured, if they get 30 or 40 billion more for Medicaid, you know, the 80 billion they have in their study goes wrong. The second problem is they assume the current levels of payment of providers are right. In fact, if you look over a longer historical period from 1980 through the current period, hospital margins are higher than they've been historically. What the MedPAC study shows that the chairman referred to is that hospitals that are under some economic pressure find ways of being more efficient. When money is rolling in, when commercial payers are paying at high rates, then they can find ways of using that revenue. So you need some economic pressure to promote efficiency. And the third point that I would say is that this is an arithmetic study. It's not a behavioral study. It doesn't look at what would commercial insurers do. Would they cut premiums if Medicare were to pay more? Would they cut premiums if Medicaid were to cut more? Or would they pocket the difference? The truth of the matter, the insurance industry is very concentrated in many geographic areas. Sometimes you have one company selling most of the business, over half of the business in a state. In fact, in nearly every state in the U.S., 3 companies or fewer control over half of the enrollment. One important reason to have a public health insurance plan available in the exchange to employers is that it is a counterbalance to undue market power by insurance companies or by providers that may be the only system that's available in a geographic area. By setting a price mark with this public health insurance plan, we can foster competition and real choice in the insurance.
Dr. Davis, my time has expired, and the chairman has been quite liberal with me, and I don't know whether Mr. Pickering want to respond.
Well, we'll have lots of time, and he can.
Well, thank you, Mr.
interject. I recognize Mr. Neal, and I'm going to ask some of my colleagues on either side. Dr. Ayanian has raised this issue also in his testimony about how the underinsured exacerbate the costs for the insured in many communities, and I hope we won't overlook that, or I'll get back to it maybe in a second round. But Mr. Neal, would you like to inquire?
Thank you, Mr. Chairman. Dr. Ayanian, the Massachusetts model has drawn a considerable amount of attention everywhere. The end result is 97%, I think, of the citizens of Massachusetts are now covered under the pioneering plan. What are the lessons learned? What are the legitimate criticisms of the initiative?
So you raise an important point about the Massachusetts health reform being a potential model for the nation. Our committee was commissioned to look at the consequences of uninsurance, and we were not asked to look at specific approaches. I think what the conclusions we draw by consensus from the evidence that we have in front of us is that regardless of the way that we choose to extend coverage and finance coverage for all members of the population, what's critically important is that we make that coverage available to everyone. Our committee followed an important landmark report that was issued by the Institute of Medicine in 2004 titled Ensuring America's Health, Principles and Recommendations. And our work endorsed the findings of that previous Institute of Medicine committee, which asserted and endorsed that coverage should be universal, it should be continuous, it needs to be affordable to individuals and families, affordable and sustainable to society, and promote health and well-being through access to high-quality care. So I think to the extent that any solution or approach to this problem of the large numbers of uninsured that we have in our country and the severe health consequences that we find when we've looked at the medical evidence, at the scientific evidence, really needs to address these principles. So the Massachusetts model is one important example where we're moving very close to universal coverage, and we hope to learn much more from that experience going forward.
Thank you. Dr. Davis, would you like to comment?
Well, I agree completely.
Mr. Pickering, would you like to comment on the Massachusetts model?
I agree. It seems like
Would you put your microphone on?
I agree. It seems like a great success in reducing uninsurance.
Just a thought, the success, at least initially, of the plan is it largely is a reflection of the fact that the business community and the labor community, as well as the consumer, they all came together to find some common ground on the way forward. And in the end, everybody accepted something they didn't like.
A mandate?
A mandate. And in that instance, I think that you can make the argument after a lot of careful negotiations and a lot of pretty hot rhetoric that there still was an opportunity in the crucible to go forward.
How did the costs come out in the Massachusetts plan?
Maybe Dr. Aania would give a better response to that. The cost?
If the gentleman yield, I'm sorry.
I would yield, yes.
So Mr. Kingsdale, the head of the Commonwealth Connector, made a presentation to our commission and showed what the premiums, and in fact, premiums went down for many of the people who had this greater variety of plans available through their connector. Obviously, the total cost went up because far more people got covered than they ever thought they'd reach. But if you look at the premiums, if you look at the cost per person, that was, in fact, in many cases, lower.
And Mr. Chairman, you simply, during the year, you receive a statement and a reminder from the Department of Revenue that all you have to do is indicate, if you have private insurance, where you have it.
Great.
And that's a very important way in which a national plan could be administered, something like a 1099-G form like they use in Massachusetts to document that they have coverage. And if you don't have coverage, get enrolled then automatically using the tax system to help facilitate that and facilitate income-related premium assistance to make premiums affordable for lower income taxpayers.
Thank you, Mr. Chairman.
Thank you. Mr. Johnson, would you like to inquire?
Thank you, Mr. Chairman. I appreciate that. My understanding was that the premiums in Massachusetts went way up, then they dropped, but not below what they were before. So I question that statement. I think all my colleagues on this side of the aisle is to have every American in the country get them access to health care, health insurance. However, I would also think that everyone would agree that not all health insurance is created equal. How many people in this room would trade their current health insurance policy to enroll in a government-run program like Medicaid? And while I'm at it, I might add that you haven't talked about CMS at all. They have not done their job very well, and they're always 2 or 3 years behind on their statistics, and probably under your government insurance idea, they're going to have to increase their oversight. So while we can listen and talk about studies that show health insurance helps people be healthier, I think we need to talk about what kind of coverage is Congress going to decide is a type of coverage that's good enough for all Americans. Dr. Ananian, when the Institute of Medicine did their review of literature, did they distinguish whether an insured person had private insurance, Medicaid, or Medicare when you looked at the health outcomes?
So we reviewed nearly 100 studies on this topic that have been published in the last 5 to 7 years. Many of those studies included both public and privately insured people, comparing them to the uninsured. Some studies focused particularly on the privately insured population relative to the uninsured. What we found, and I think you raised an important point, it's not just having an insurance card, but it's what that insurance card covers, what it gives you access to. And it's very important that, for example, people with chronic conditions, what we might think of as the silent killers in the American population, such as high blood pressure, or diabetes, or unrecognized heart disease. There are many things that medical care can do very effectively to identify health risks early on, to treat those risks and reduce the chance of costly complications like heart attacks, strokes, kidney failure. So it's, for the most part, the research literature that we identified was comparing people who had any insurance to no insurance. And there was a clear message there that no insurance is the wrong level of coverage, and there's no doubt about that from a health perspective. We also learned from the types of studies that as medical care has made more progress, in fact, we run the risk of the gap between the uninsured getting larger in terms of the health consequences. So as we get better at treating depression and diabetes, heart disease, detecting cancer at an early stage when we can cure it, that's the kind of coverage that we need to give people access to. So in the existing studies, sometimes that coverage is available through public programs, sometimes through private programs. In either case, it's better than being without insurance at all.
Thank you. Well, I don't think we have to look very far to see there's a difference in health outcomes, as you indicate, based on what kind of insurance you have. In this area alone, there have been children who've literally died from toothache because they, even though they had health insurance, Medicaid in these examples, they didn't have access to a doctor. The Medicare program is showing similar signs, and I have heard of seniors who have become eligible for the Medicare program and can't find a doctor who will take new Medicare patients. That's a problem across the country, I think. I think this committee would be doing a disservice to our constituents if we didn't just talk about getting people insurance without discussing what type of insurance we're going to be offering. Ms. Davis, the Commonwealth Fund included a government-run plan in their reform proposal. Is that right?
The framework, it creates a national health insurance exchange. It does offer private plans and a public health insurance plan.
Well,
but people can keep what they have if they want to keep what they have.
Yeah, okay, but after your proposal is fully implemented, how many Americans would be enrolled in some sort of government-run health care program?
It depends on whether the private insurance industry continues premiums going up the way they are. But if they respond to the competition, they could hold on to market share. In the worst case, 105 million would still have private coverage, largely sponsored by employers, either purchased directly by employers or choices that they pick once they are enrolled through the National Health Insurance
That's private plans. How many are in government plans?
The balance is about, of the working age population, setting Medicare and Medicaid aside, about 35% of the population would be in a private plan, 34% in the public health insurance plan. So there's a balance, and that's the worst case scenario. That assumes insurance companies do not respond to the competition, do not take advantage of some of their inherent strengths. So roughly equal.
I don't know. I think 188 million is what you said earlier, I think, which includes Medicare, Medicaid, and SHIP, all would be insured under government plans.
About a fourth of the population are covered by Medicare and Medicaid. Some of those now covered by Medicaid actually go into their employer plans because they have premium assistance to help afford their share of the coverage. But others would, of the uninsured, About 26 million would get coverage through the National Health Insurance Exchange, have these various private plans available to them. About 13 million would go into Medicaid. So Medicaid stays at about the same, going from 42 million to 49 million on balance. Medicare stays at about the same, going from about 39 million to 41 million. So the public programs stay about, the current programs stay about the same. But private insurance would have, again, this is assuming they don't respond to competition, continue business as usual, premiums continue to go up the way they've been going up, then private insurance would have about 105 million of the working population market. Public plans would have just a little bit less. That private would have 109 million. Public health insurance plan would have 105 million.
Okay, my time's expired. Thank you, Mr. Chairman.
Thank you, Mr. Johnson. Mr. Becerra, would you like to inquire?
Thank you, Mr. Chairman, and thank you to the three of you for your testimony. We appreciate your helping us kick off what we hope will be a series of great hearings to try to take us to a place where we really do reform this healthcare system and make it far better. It sounds to me like, from what I'm hearing more and more, that we should rest this reform of our system, not someone else's system, not some other country's system, but our American healthcare system.
I agree.
We should rest it on a few fundamental pillars. One is consumer choice. All of us as Americans who seek out healthcare should have a choice. You like who you have, you like your health insurance now, you should get to keep it. Maybe we'll even make it cheaper for you because we'll make it more efficient. No free riders. We should all share in this responsibility, and everyone should participate. You have some who say, no, I don't need to, I'm still young and healthy. You may get hit and all of a sudden by a car, and all of a sudden now you're our responsibility. So everyone should participate, no free riders. And of course, no lemons. None of us wants to find out that we're paying $5 for an aspirin tablet when we go to the hospital. And so no one should be asked to pay for anything less than quality health care. And so those seem to be three very fundamental pillars that we should all really seek to achieve when we talk about health care reform. And on the issue of choice, which also includes the issue of competition, we want to make it robust. So consumers are the ones, should be the ones that choose who their doctor or provider is. It shouldn't be the other way around. And in that regard, I'd like to ask Mr. Pickering a question. You talk about this cost shifting and why we shouldn't have a public health insurance option. Most Americans would say, I want to have as many options as I can. I'll select. Don't tell me I can't have this option. Let me decide if I want that option or not. But it sounds like you're saying, no, let's not give folks that particular option. Do you believe that today we should eliminate Medicare?
No.
No. Now, that's a public health insurance plan that seniors get today. Some 48 million seniors rely on Medicare, and that's a public health insurance plan. Do you think the Veterans Health Care Services, through the Veterans Administration, that our men and women in uniform who are now veterans receive should be eliminated?
No.
Okay, and that's also a public health insurance plan, is it not?
Yes.
Okay, so you would want to tell veterans, you can choose. If there's a private health insurance plan out here, you can choose that, or you happen to have access to the Veterans Administration's hospitals and doctors, and you can choose that. But we leave it to the veterans to decide where they go, right? Correct. And to seniors, a senior can collect, use its money to buy a private health insurance policy today, or it can choose to use the Medicare program that's available to a senior today, some 48 million seniors. That's a choice they should get to make versus any of us, right?
Agreed.
Okay. So now, my question is, why is it okay for seniors to have all that choice? Why is it okay for veterans to have that choice, but not decide to allow all those Americans who we're trying to bring into the system so we can make it far more efficient and cost less, that they get to have that choice of deciding whether it's a private health insurance plan or some public health insurance plan that might be an option to them as well. Something similar to Medicare, and Medicare for middle-aged Americans. Why would you want to limit an American's choice to a Medicare-type health insurance plan?
It's not that I would want to limit the choice. It's that I fear that with the current payment structures of private plans versus a public plan at Medicare rates, that the payment plan or the private plans could not compete against those rates.
Because
And-
what you call the cost shift.
well, can I draw one distinction? So it's interesting in the Medicare Advantage program, you have the government plan, traditional Medicare, competing against the managed care plans.
Yes.
Most of those managed care plans are able to contract at approximately 100% of Medicare with providers, because providers will accept that for Medicare patients.
Right.
It's not the same situation on the commercial side right now in the country.
Actually, it's interesting that you would bring up the private for-profit health insurance plans that participate through the Medicare Advantage program within Medicare, because in a way you have a private plan within a public health insurance program, Medicare. And everything I've seen, it shows that those private for-profit health insurance plans within the Medicare system actually get reimbursed at higher rates than those doctors and hospitals that are going through traditional public health insurance plan options within Medicare. And so that would seem to me to actually show the cost shift going in the opposite direction of where you're saying is that you're saying that right now we're shifting costs from the public sector, the public health insurance plans, to the private plans, when in fact you have the Medicare Advantage program, which actually shifts the costs from taxpayers, from the Medicare private for-profit plans to the taxpayers. And also, if you take a look at, and I know Mr. Chairman, my time has expired, if I can make this last point. I should take you down to Los Angeles, where I live. In my county of Los Angeles, the county hospitals take care of any number of people. Only 8% of the people that come in through the doors of the county hospitals in Los Angeles are covered by private, for-profit health insurance plans in combination with Medicare. And so what I see, at least in Los Angeles, is that public health insurance plans and options are subsidizing private for-profit health insurance plans that are unwilling to offer plans to the poor or the sicker Americans. And as a result, the public hospitals and these public health insurance plans are having to take the burden of the fact that the private for-profit health insurance plans aren't yet willing to take all these millions of Americans. And so I'd actually say you should take a closer look at your study. It looks to me like the cost shift is occurring in the private for-profit health insurance plans, shifting costs onto the taxpayers who end up paying through these public hospitals or through programs, public health insurance programs like Medicare and Medicaid. Thank you. Thank the chairman for the time.
Thank you. And Mr. Doggett, would you like to?
Thank you very much, Mr. Chairman, and thanks to all of our witnesses for your testimony this morning, although I believe my questions will be directed just to Dr. Davis. You know, we have focused this morning on the millions, but I think it is important to keep remembering the way this crisis is affecting the lives of people across the country. And I was reminded about that again last week when I had communications that I received from neighbors in Austin, Texas, and the stories of two women. One, a younger woman, Lisa Elmore, wrote me about her experiences as an employee at a small business in Austin that had several employees that were of childbearing age, and because of the high cost of premiums, the small business could not afford insurance. The first time that she got ill on that job, she said she just toughed it out, missed some days of work, but couldn't afford to see a doctor. The second time, she went to several clinics because her problems were so severe, and finally was able to go to a local clinic, a wonderful facility called People's Clinic in Austin that tries to serve the uninsured and does a really good job at it. And she said, though, that then the prescriptions that she had to buy, since she was uninsured, she had to pay the highest price for prescriptions, took most of her income, and that it really set her back significantly to have to delay care and then to have so much of her income taken by health care. The other woman is an older woman, and her son, John Mason from Austin, wrote me about his 62-year-old mother who, like so many others, in this terrible economy we inherited from the last administration, lost her job after 29 years. She had a heart attack and subsequent bypass surgery, and she's never smoked. She followed her doctor's dietary suggestions, but she's without insurance to cover the problems that she has, and now if she is able this late in life to get another job, her pre-existing heart condition will weigh against her. He says, it's truly sad that after 3 decades of service to one company, my mother is now frightened that she will no longer be insurable with since she had this heart attack and a stroke, these kind of problems. I think, Dr. Davis, that your study confirms, does it not, the urgency of addressing this issue, not next year, but this year, as President Obama has fortunately indicated he wants to do.
Absolutely. President Obama said it was these kinds of stories that he heard on the campaign trail that broke his heart, and I think they illustrate much of what's wrong with the current system. When people work for a small business and that small business can't afford to provide insurance or has to drop the coverage or has very limited coverage, the uninsured pay a higher price than anybody else for prescription drugs, for physician visits, for hospital care, because they don't get the discounts that people who are covered by either a public health insurance plan or by Medicare. Older adults, a woman 62 years old with a heart condition, it has very few affordable options available to her. She is not going to qualify for insurance on the individual market. And Mr. Becerra is absolutely right. That's a cost shift from the private sector to the public sector. They're the only ones who will take the disabled. They're the only ones who will take children who have developmental disabilities. So the sickest tend to eventually find themselves onto Medicare or Medicaid. But for the disabled, this woman would have to wait 2 years, really 2.5 years, to qualify for Medicare as a disabled person. And she cannot find a plan that will take her at all. She certainly cannot find a plan at an affordable premium. So we must act, and must act now.
And Mr. Becerra just pointed out, when John Mason's mother is 3 years older, she'll be eligible for a public option. If she were a veteran, she'd be eligible for a public option. It's difficult to understand the resistance of some people. I think it's based more on ideology than reality to providing a public alternative. You responded to Dr. McDermott and his questions earlier, but if the goal is to contain cost and assure coverage options for everybody in America, isn't having a public option, a public plan, essential for reform of our healthcare system?
And absolutely, and it really goes right to the heart of it when you consider disabled and older adults. Let them buy in to Medicare early. Eliminate the 2-year waiting period for the coverage of the disabled when they need coverage the most to treat their cancer, to recover from a heart attack.
And Mr. Chairman, you have had an excellent bill to do just that. Let me just say in conclusion that I think, adding to what Mr. Becerra said, we have already excellent evidence on the importance of the public health option under Medicare. Under Medicare Part C, we have the public option. Under Medicare Part D, we haven't had it. And Medicare Part D began with many plans. It's now consolidating. The rates are going up. The subcommittee on health that you chair, has studied the many problems with Medicare Part D. I think it's difficult. I think it's amazing that anyone would look at the Part C experience versus the Part D experience on prescription drugs and not feel that any plan that omits the public option is just not much of a plan. I yield back. Thank you.
Thank you. If you want to talk more about my great bills, I'll yield you some more time. Mr. Lindner, would you like to inquire?
Thank you, Mr. Chairman. Mr. Pickering, we've heard a lot about options today. Consumer choice, let the individuals make their choice, give them options and they make their choice. For the last 40 or 50 years in the private healthcare market, who made the choice? The consumer or their employer?
Employer.
So you can give all the choices in the world, that consumer's still going to go with what their employer decides to pay for. Kaufman Rand has done a study on how much it costs businesses to provide health care for their employees. Among all firms, that's 7 to 10% of the payroll cost. Among smaller firms, it's 11% of the payroll cost. Among half of all small businesses pay 10% plus of their payroll costs to provide health insurance for their employees. This proposal suggests that Dr. Davis has put forth that the penalty for those companies not providing health insurance will be 7% of their payroll costs. Now, if you were the owner of that business and you're paying 10% now and you could get out of it for 7% and let the taxpayer pick it up with a government-run program, what would you do?
You'll tend to find employers dumping their plans.
In large numbers. Right now, about 120 million people say they're satisfied. But out of those 120 million people, a very small percent are going to get any choices at all. Isn't that correct?
I believe so.
Their employers are going to make that choice for them. Yep. Dr. Davis, you said under the worst-case scenario, 1/3 of Americans will be in private plans and 2/3 will be in government plans. And you said that is only if the private plans do not respond to competition. Well, they do respond to competition in the private sector today. But if you're suggesting that they have to respond to competition in a government program that is subsidized by taxpayers and mandates, how can they compete?
Well, first of all, the private plan administrative costs go down through the exchange. For this small business you're talking about, now they're paying for firms under 50 employees 22% in administrative overhead. For those under 10 employees, 31 to 36% of the premium goes for administrative overhead. If they buy even a private plan through the exchange, that will drop to 12 or 13%. So they're
Or they can go to 7% and dump it on the taxpayers.
they are required to either provide
Let me talk about
coverage
another worst-case scenario.
or contribute to a fund.
Another worst-case scenario was 1965, and President Johnson was proposing both Medicare and Medicaid. And there were questions as to the costs of those programs down the road. And President Johnson said, using easily quantifiable user statistics, I can tell you that by 1990, Medicare will cost $9 billion and Medicaid will cost $1 billion. And we're a wealthy nation and we can afford that. Well, those easily quantifiable user statistics disappeared when other people were paying the bills. And Medicare costs about $100+ billion, and Medicaid costs about $76 billion. How comfortable are you with these worst-case scenarios and your user statistics?
Well, I think one lesson from Medicare and Medicaid is that we cannot accept the delivery system the way it is now. We need to change away from fee-for-service payment that was the basis of Medicare, which was built on the private insurance methods when Medicare came in, to new methods that really reward physicians for controlling chronic conditions, new methods that reward hospitals for keeping people well after they leave the hospital. We know what trend we're on now, and that's what we can't afford to continue. There are potential savings from these new models of payment. There are potential savings from new methods of care where people enroll with a physician practice and really hold providers accountable for both giving good care, great outcomes, but prudent use of resources.
Yes, what you're talking about is in potential savings in a variety of areas as long as the government has enough people to oversee the doctors and tell them how to do it. But none of that adds to the options or choices of consumers. This program is going to drive people out of the private markets and into government-run health care, and you and I both know it. I yield back, Mr. Chairman.
Thank you, Mr. Linder. Mr. Pomeroy, would you like to inquire?
Mr. Chairman, I would, and I thank you for the opportunity. I used to be a state insurance commissioner. I've spent a lot of time thinking about these options. I believe that a public plan option within the exchange is a very important part of the program, and as outlined by the Commonwealth report, there's a very important relationship to whether a public plan is available within the exchange and our ability to get coverage to those who don't have it. So we can get coverage to those who have it, allow people to keep what they have if they want, give them another option if they want, and that's how it all hangs together. I really do believe that failure to have the public plan is going to raise real questions about whether we can do the job we want to do in getting coverage to those who need it and don't have it. All right. But there's some other things where I believe we can all agree, and I would hope my friends on the other sides of the dais as well, and that's incentive reform within medical care delivery to improve outcomes and achieve some cost efficiencies. Mr. Pickering, I noticed in your last line of testimony you seem to allude to this possibly being an area of common ground. Quote you, to be successful, the long-term reform must address both the financing of care and the cost efficiency and quality of care delivered. So what do you mean by that?
I believe in the country today, our healthcare system is very fragmented. When you look at some of the best practice private plans out there, there are integrated delivery systems that deliver the best care for the lowest cost. I think we need to try to model reforms to integrate the rest of our delivery system.
I am very proud to represent an area that has largely integrated systems. 5 of the 6 large medical centers in the state I represent are integrated, primary care focus, and you are absolutely right. The Medicare data is showing we're achieving high outcomes for among the lowest costs in the country. Dr. Davis, what can we do to evolve our care delivery systems along this way?
Absolutely. One of the main thrusts of this would be to encourage the growth of private integrated delivery systems. We took our commission, as you know, to North Dakota, looked at the very fine results that you're getting with many of the integrated delivery systems in North Dakota. In fact, our estimates are that 50 million people would enroll in these private integrated delivery systems, and they have the ability to both improve care by the way they control chronic conditions in your state and have lower costs. Right now, a small business often doesn't offer these community health plans that are aligned with integrated delivery systems. They can only offer one choice. Once the employer decides to take their employees into the exchange, they have access to all of these community integrated delivery systems. So those systems don't have to invest in marketing, salespeople to go out and visit all these small businesses. All of a sudden, they have an access to a much broader enrollment market, and they are the ones that are going to thrive in this kind of competition.
One question I've got involves the evolution of our reimbursement system. We've got literally a stunning disparity in reimbursements. I'm not just talking about the underpayment in certain parts of the country, but just the cost for which Medicare pays care on a per capita basis. 05 data shows that a Medicare enrollee in Miami, Florida, involved $14,000 in health care costs. In Rapid City, South Dakota, it was $5,000. You know, this is a program for the country, but basically we feel like we're surely not reaping the kind of support that goes to other parts of the country. There must be something going on that is driving this differential in cost that is not related to quality of care delivered. And in fact, from an outcome analysis, if I can make any sense of it at all, it's the more it costs, the worse it gets. And the lowest it costs, the better it gets. Now, how do we, Dr. Davis, how does Commonwealth try to address this overpayment? How do we ever get this straightened out?
Absolutely. We have a map of the United States that shows those areas that over 125% of the median in Miami shows up in red. All of North Dakota, you'll be pleased to know, is white, and under 105% of the median. So I think we have to look at things like our update policy in Medicare and look at how we reward areas that have done a good job of integrating care, controlling chronic conditions, and apply some economic pressure in these areas that, as you say, are almost 3 times as high in terms of Medicare spending.
Thank you, Mr. Chairman.
Thank you, Mr. Pomeroy. Mr. Thompson, would you like to inquire?
Yes, thank you, Mr. Chairman. Thank you for holding the hearing. And I'd like to thank Mr. Pickering for his comments about the VA medical system and the importance of keeping that as a disabled war veteran. I've used their services in the past and sometimes use them currently, and it's outstanding public system. So I think that everybody recognizes the importance of maintaining a public component to our delivery of health care. And I also recognize that we need to change the way that medical care is delivered in this country if we're ever going to get our arms around this enormous problem. And I appreciate the commitment that this administration has made to doing just that. And Dr. Davis, your study also speaks to this. And I'd like to just focus on one aspect of that needed change, and that's the expansion of preventive health care in health care today. And I think it's extremely important that we do a lot more to provide preventive health care for children, to make sure that we can detect problems before they become acute and more harmful and more expensive, but also an expansion of preventive health care for adults. The good example is the Welcome to Medicare program, and how we really need to grow that and make sure that folks get the screening necessary that go into that. And the IOM report talks about the access to preventive health care without health care insurance and how that's impacted. And Dr. Davis, I'd like to hear what your recommendations are to ensure that we can implement a much more comprehensive preventive health care system here in this country.
Absolutely. That has to be a very key part. As Dr. Ayanian's own research has shown, investing in preventive care can have payoff in terms of better health. It can also improve the health of older adults as they go on to Medicare. In terms of the framework that's set forth here, there are a couple of things that try to focus on prevention. First, the public health insurance plan would lower any cost sharing for preventive services. So just as you've done with Medicare to make sure that people are getting colon cancer screening, getting breast cancer screening, the cost sharing for that would be eliminated. The second thing it does is this emphasis on a medical home. North Carolina has shown that if you pay physician practices a medical home fee and you provide support from nurses to work with families, that you can reduce pediatric asthma hospitalization rates. So that type of intervention, the medical home investment, nurses to work with families can work. In addition, we include in our plan monies that would go to state and local government to work with schools on childhood obesity, to work on smoking cessation programs, make it easier for employees to participate in those kinds of programs.
Thank you. And Dr. Ayanian, that IOM study talks about the effects of the uninsurance and communities that are impacted differently in regard to, I think you say small communities is what you talk about. But I represent a rural district, and we have this, I think, the same barriers, access to expensive and specialty type care. How do we address that issue in rural and, I guess, small communities?
Sure. What we find, based on the available research, is that communities, large or small, rural or urban, with high rates... Underserved, basically, with high rates of uninsurance, the insured population in those communities can be adversely affected. There are strains on the healthcare system, particularly for services that require a high initial investment, such as trauma care, cancer care, advanced cardiac services for people with heart disease. When those fixed costs are high and there's a lower rate of insurance in the community, the hospitals in those communities are less able to invest in the services for the whole community, both uninsured and insured. Doctors are less willing to locate in those communities. That can play out in trauma care, for example. If a hospital is the trauma center for a region and there's a large proportion of uninsured individuals in that area, it's harder to obtain the types of specialists, such as neurosurgeons or orthopedic surgeons, that we all need when someone's in, for example, a severe motor vehicle accident, so that insured people can be affected in those communities with high rates of uninsurance. We also find that insured people in survey data are less satisfied with the care they're getting. We commissioned some work by Mark Pauly, a health economist at University of Pennsylvania, Jose Pagan at the University of Texas. Their work shows that insured people in those communities are just less satisfied with their access to care and their quality of care because of these financial strains in the system.
So the greater the expansion of the risk pool, the better the services and the lower the cost.
That's right.
Thank you very much. I yield back.
Thank you. Mr. Tiberi, would you like to inquire?
Yes, Mr. Chairman, thank you. Dr. Davis, I represent a district in central Ohio, and for years I've had hospital officials and docs complain to me about Medicare reimbursement rates, Medicaid reimbursement rates. Your plan appears to acknowledge a portion of this by increasing Medicaid reimbursement rates to the Medicare rates. Why did you do that in your plan?
Thank you. Obviously, Medicaid has been a problem, as we've seen from the study that Mr. Pickering has talked about. It has underpaid to the point that doctors don't participate. We think it's very important to bring Medicaid payment rates up to the Medicare level. It's also important to address the imbalance in the Medicare program. I think it's clear we underpay for primary care. So what this proposal would do would be to have a 5% increase in primary care, office visits called evaluation and management services. It would also provide a medical home fee to primary care physicians. Nonetheless, having said that, the MedPAC study shows that nearly all doctors now participate in Medicare, and it's easier for a Medicare beneficiary to get a specialist appointment.
Did you just acknowledge, though, that you said, did you say that primary care docs are under reimbursed in Medicare?
Primary care physicians are underpaid, in my view, by Medicare, as well as by commercial insurers that follow Medicare payments, but they pay a bit more than Medicare. They pay a lot more than Medicare for specialists, so they kind of perpetuate that imbalance between primary care compensation.
Dr. Pickering, isn't that essentially what you've testified to, that the fact that Medicare and Medicaid reimburse less, and therefore there's a cost shifting to help the hospitals and providers recoup some of that loss?
Yes, that's exactly the cost shift.
Can you expand on it? What's happening out there?
Yes, in many communities, take my hometown of Seattle, commercial plans would pay a doctor around a, I don't know, $52, $53 conversion factor. What that means is for an office visit, maybe they pay $70, whereas Medicare might pay $50. Now, different health plans will pay primary care and specialist care at potentially different rates, but across the board, commercial plans will pay both primary care and specialty care at significantly higher than Medicare. Now, I do want to stress it will vary geographically. There are some areas in the country where commercial plans pay on par with Medicare.
So if I run a hospital, a nonprofit hospital in Columbus, Ohio today, and essentially I'm losing money on Medicaid and Medicare reimbursements, which I've been told happens, and I am making up for that with private insurance reimbursement under your, and I don't want to put words in your mouth, but under your thought or study, you're saying that if we expand public options, government options, the more government options crowd out the private options, the more difficulty it is going to be for the private options to continue, and the more difficulty it's going to be for hospitals and certain providers to survive.
That's right. That's right. As you have less people enrolled in the commercial plans that are effectively subsidizing the public plans, you have less money going to the providers, and providers face more financial pressure. They need to either become more efficient or put an even higher burden on the remaining commercial membership.
Or we could substantially increase reimbursement rates for Medicaid and Medicare to providers, hospitals, docs.
Yes, for example, like an FEP plan pays much higher rates than Medicare.
How much higher?
FEP pays commercial rates. It's administered by Blues and other plans around the country.
And that would go to both hospitals and primary care and specialty docs?
That's correct.
Across the board?
Mhm.
One final question across the board. I just want to see if you guys acknowledge this number. I got a U.S. Census stat that says in 2006, 20%, nearly 20% of the uninsured in America, this is a U.S. Census Bureau stat, lived in households that had an income, IRS income limit of $75,000 or above. So nearly 20% of Americans, of the uninsured Americans, lived in a household where the income was $75,000 or above. Can you comment?
That's roughly right. About a third have incomes below the poverty level, about another third below twice the poverty level, which for a family would be about 45,000. So yes, there are about 10, or maybe it's as high as 20, who have incomes above 75,000. But with premiums now being $15,000 a year, or $13,000 for a family, even a family with 75,000 income would have to pay 20% of their.
I don't have a debate with you about it. I just want to know if you thought that number was right. I've run out of time, Mr. Chairman. Thank you.
Thank you. I think 45 minutes? The committee will recess for 45 minutes. My understanding there are 3 votes. Give the witnesses a chance to stretch.
Can we, Mr. Chairman, can we just ask, Mr. Chairman, can we just ask one more vote? Can we-
Pardon?
Wait, we got 15 minutes to vote. Can we have?
If you'd like, sure. We could have some more, but we'll come back at 12:45. And in the meantime, if Mr. Larson would like to inquire, he can proceed.
Thank you, Mr. Chairman, and let me thank you and the panelists for their very thoughtful presentation and their responses to members' questions. My questions are for Dr. Karen Davis. Dr. Davis, in my state of Connecticut, we have lost more than 40,000 jobs this last year, and have already lost over 3,500 in this January. When we talk about portability in health care,
If our guests could, if they're rushing for lunch, if they could do so quietly so that our witnesses and the members can hear, appreciate it. Thank you very much.
usually when we're talking about portability, we're talking about people moving from one job to another. What are some of the ways you would propose to make sure that someone who has lost their job, especially in this kind of economy, can maintain their insurance coverage at a rate that they can afford? The stories about COBRA coverage being just out of reach for so many begs this question. And secondly, one of the biggest causes of bankruptcy in our country is medical debt. And for many of my constituents, having a serious health condition that has led to financial ruin, even if they had health insurance. How would this new system be designed to deal with catastrophic health events, and how much of the burden of paying for catastrophic health care costs would fall to the government or the private sector?
Well, I think your district is feeling the pain that a lot of American communities are feeling with the severe economic crisis, unemployment at over 8%. We don't know where it's going. So portability of coverage is very important. Under the PATH framework that we put forward today, eventually about 70% of the workforce, the employers, would buy the coverage through the exchange. And so people in those kinds of employment situations could hold on to their coverage and wouldn't have to change because they've lost their job. But you're pointing to the affordability of the premium, and that...
and also to the fact that if you're unfortunate enough not to have another job, but you still have a family and you're existing under COBRA payments, how do you envision those payments being affordable payments as we go forward?
So what this does is set a ceiling on the premium as a percent of income. So in the lowest 2 tax brackets, you would never pay more than 5% of your income toward the premium. The rest would be provided through general tax revenues. The For the other tax brackets, it would be 10% of income would be the maximum you would have to pay for premiums. And that the benefits would be based on what members of Congress have, the standard option, Blue Cross Blue Shield, federal employees benefits. So it's comprehensive, doesn't make you bankrupt when you have a serious illness. So it's both comprehensive benefits and premium assistance that guarantees that you're not paying more than a reasonable share of your income.
Now, for those, how does this plan envision dealing with catastrophic health occurrences and catastrophic health?
There is a ceiling on out-of-pocket expenses, again, modeled on the standard option Blue Cross Blue Shield. So it's roughly $5,000 for an individual, $7,000 for a family. The deductible is $250 a person, $500 for a family. Basically about 25% coinsurance for drugs, 10% for physician services, but a ceiling on out-of-pocket costs of something like $7,000 per family, and a ceiling on your premium obligation as a share of your income.
Dr. Ayanian, what are some of the proposals, of your proposals, to create incentives in terms of prevention and wellness?
So our committee reviewed the evidence on the types of preventive services that make a difference for children and adults. So for children, for example, immunizations, basic dental care, well child screenings, preventive asthma care to keep kids healthy at home as opposed to getting sick and ending up in emergency rooms and hospitals. We know that those problems are much more common for children when they're uninsured, and when coverage is expanded to uninsured children, their risk of those problems goes down. Similarly, for adults, we know that there's just a number of very important medical services, cancer screenings, screening for cardiovascular risk factors like
Is there a
diabetes.
cost-benefit analysis to that in terms of the direct correlation between prevention, wellness, and preventative care, and what the cost savings is? Or
I can't put an exact number on it for you, but we know from a number of studies that when children or adults get effective preventive services, particularly those with chronic conditions where, in fact, we're preventing more immediate complications. There's primary prevention for the long term. There's secondary prevention for people who already have an established condition such as diabetes or heart disease. And we know that when we provide them with the right preventive services, their risk of complications go down, and their risk of the costs associated with those complications also goes down.
Thank you, Doctor.
Mr. Blumenauer, would you like to wind up this part of the session?
Thank you very much, Mr. Chairman, and I do appreciate the testimony that's been advanced. I think we're getting the context here that's going to be extraordinarily useful. I have two questions that I would put. There may not be time for you to elaborate, but there seems to be a straw person reflexive challenge that is being posed to this in terms of the threat to the private insurance system that we have now through employers. Dr. Davis, can you just summarize the downward trajectory that the current system faces for the threats to private employer-provided insurance if we don't have a comprehensive approach like you're describing?
Absolutely. If we stay on our current course, we're going to go from 46 million uninsured to 61 million uninsured, and nearly all of that's the erosion of employer coverage. So businesses need effective competition that will slow the growth of private insurance. It's not an option to continue on our current path.
I appreciate your saying it again, but that's something that needs to be like a beacon. We're in a downward spiral now. The status quo is no longer the status quo. It's higher co-payments, it's worse service, and it's less coverage.
Absolutely.
The other straw man that seems to be established is this fear that of comparative effectiveness research. Somehow, if we find out and document what works, that's going to lead to unacceptable intrusion into the practice of medicine. I am reintroducing legislation on end-of-life treatment, where right now Medicare doesn't even pay a doctor to talk to families about the choices they face, and too often people are steered to intensive, invasive, disruptive, expensive treatment that doesn't add to the quality of life, doesn't even extend life at great expense. Can you speak to, for a moment, to the benefits of our actually doing this comparative research so that we know what we're getting into?
Certainly, I can address your question as a practicing physician myself. And my colleagues and I practice in the Boston area, but colleagues around the country, we want the best possible evidence to serve our patients. And it's difficult for any individual physician to know what the best way is. We learn from studies of many patients and comparing different treatments. Personal experience of a talented physician is obviously very important, but the best medical care comes from blending that clinical experience with effective evidence, scientific evidence about what works and the relative pros and cons of different treatment options. So I think in terms of developing a more efficient and equitable healthcare system, anything we can do to improve the quality of the evidence for making medical decisions will benefit our patients.
Mr. Chairman, I appreciate the hard work that you've been doing. I'm hopeful that we're going to be able to actually do a little evidence-based research ourselves, look at what is happening to the system, look at realistic options, give people more choices, more ammunition. I'm convinced that we can meet our goals, save money, improve the quality of health care in this country in a way that's entirely consistent with what the stated goals are, but somehow people talk past each other. I appreciate your courtesy.
Well, thank you, and I'll look forward to your assistance. We'll now recess. It'll probably be closer to 1 o'clock before we get back. I'll see if the staff can find the witnesses some refreshments, and we'll see you in about 45 minutes.